I'm Harriette Van Spall, a cardiologist and clinical trialist, and I am so delighted to have with me Professor Helene Eltchaninoff, Professor of Medicine and Head of the Department of Cardiology at the University Hospital of Rouen in France. And we are here at ESC 2024 with our friends at Radcliffe Cardiology to discuss her exciting late-breaking clinical trial presentation of the RHEIA trial, the randomized research in women with aortic stenosis. Welcome, Professor Eltchaninoff.
Yes, hello. Nice to meet you.
So good to meet you. I wonder if you would start by giving us some background on the rationale for this trial.
Yes, of course, there is a rationale for this first, in fact, randomized trial in women with aortic stenosis undergoing intervention. So the rationale is that women, in comparison to men, have different characteristics for aortic stenosis. They are also underrepresented in current randomized trials. Also, it has been shown that the risk of mortality is higher with surgery, and the benefit from TAVI is better for a woman than for men. So there is this rationale to compare a surgery to TAVR in women with aortic stenosis.
Sure. What was your hypothesis?
The hypothesis was that it was non-inferior to surgery, and even superiority could be tested if we were able to reach non-inferiority. And there is a primary composite endpoint, of course. The primary composite endpoint on which we want to demonstrate non-inferiority and even superiority is a combined endpoint at 1 year, combining death, stroke, and rehospitalisation. So it's the same endpoint as the partner 3, for example.
Wonderful. And this was a parallel, open label, one-to-one randomization trial. Tell us about the eligibility criteria.
Yes, so only women could participate to the trial. Women had to have a severe aortic stenosis as defined by a typical pattern on even and low risk following the current European definitions. They had also they could be all comers, so whatever the surgical risk, they just needed to be able to undergo either surgery or TAVR in this trial. And we had few exclusion criteria, which were bicuspid valve, unicuspid valve, a coronary disease not accessible, or different patterns which could not allow either surgery or TAVR in this woman.
So really pragmatic eligibility criteria. What about your study design? Can you tell us a little bit more about your non-inferiority margin, how you went about setting it, and what were some of the considerations in that selection of the margin that you chose?
Yes. So the trial was designed it was a non-inferiority trial. I can give you the details. The details was to have a non-inferiority margin of 6%, and if the non-inferiority was tested and reached, we had a pre-specified superiority test in case it was reached. So we had both non-inferiority trial, but a pre-specified test for superiority. And we calculated the sample size, both for non-inferiority and to be able to reach superiority in case of non-inferiority test was passed. So the sample size was more than 400 patients and randomized into two groups.
So an absolute margin of 6% seems wide. Why did you choose an absolute rather than a relative margin?
In fact, it was the same as in partner 3. So it was decided to use the same because it has been demonstrated that that it was the from this trial.
Okay. And then with an absolute margin, the power is contingent on a certain event rate. So what event rate were you anticipating?
So we're anticipating a 16% combined endpoint with surgery and 8% with a TAVR.
Okay. And so your primary endpoint was a composite of
death, stroke, and rehospitalisation at 1 year.
Okay. Can you tell us about the baseline characteristics of the patients in your trial?
So the two groups were very well balanced first. So this is good for randomization. Mean age was 73. They were at low risk since STS score was 2%. They had severe aortic stenosis, but typical pattern, like 0.8 centimeter squared. They had normal ejection fraction. And what is interesting is that 70 to 75% of patients, of women, had a small annulus, less than 430 millimeters square on CT scan. This is what is interesting. Of course, we know that the annuli are smaller in women, but here 75%, it's a big population of small annuli, and it's very interesting to evaluate this category.
Which is why it's so important to have these types of trials when there are anatomic considerations that account for some of the sex differences that we only learn about when we have trials such as yours. And how did you incorporate patient preference? I mean, this was a randomized trial, of course. Did any of the patients not receive the intervention that they had been randomized to? Were there any crossovers based on patient preference, for example?
Yes, of course, it was something which was interesting because usually patients, they prefer TAVR. So, but we were explaining that in Europe, the cutoff was 75 to be able to receive TAVR if transfemoral access was feasible. So when they were younger, it was not so difficult to randomize because they had a chance to get to TAVR. In fact, we had a few crossover because after randomization, we had some failure for screening, of course. We had some patient refusal and some physician decision after randomization. So we had a few patients which are out before the two final group of as treated patients.
And did you measure frailty in this trial?
Yes, we measured frailty. Everything was balanced according to patients' characteristics and the valve distribution, etc. Very few were frail. And we can understand that very few patients were frail because they had both to be able to undergo surgery and TAVR. So usually frail patients, surgeons don't like too much to operate on frail patients. So the rate of frailty was very low. It was less than 1.5%, and it was also well balanced between the groups.
Can you tell us about the valve types used in the TAVR group?
Yes, the valve types were exclusively balloon expandable, Sapien 3 and Sapien 3 Ultra, mostly Ultra, which is the latest generation in Europe. And concerning surgery, it was per protocol any commercially available valve, but mostly, like in 60% of cases, the gold standard, like the Magna is the valve. And we had also a few Intuiti and Perceval valves. We can say also that the distribution of sizes is very interesting because for TAVR, we had mostly 23 millimeter valves, like in 63% of cases, no 20 millimeter valve, so no extra small annuli. And when we look at the surgical group, we had also mostly 23 millimeter valve, but we had also 45% of smaller, like 19 and 21 millimeter. Something which is also very interesting is that there was no aortic enlargement performed by the surgeon in combination to valve replacement. There were a few CABG, but no enlargement, which is a big subject, in fact, when we discuss about women, small annuli, etc.
And of course, you haven't made your presentation yet, so I don't know all of the results, but in terms of the baseline characteristics, the EF was generally preserved, right?
It was preserved. It was normal. In fact, it was 60%, and again, very well balanced between groups, 67% even. So it was a normal ejection fraction. Yes.
Tell us about your primary treatment effect.
So we were very happy to demonstrate a non-inferiority and even superiority of TAVR over surgery on the primary endpoint at 1 year, with a difference on the Kaplan-Meier estimates of twofold lower with a TAVR of 8.9% at 1 year. So we're very, very happy for this important information. And another information which is very important is that both techniques provided really excellent results at 1 year, with a mortality rate at 1 year, which was very, very low, like 0.9 for TAVR, 2% for surgery. So excellent results for both technique, but a twofold lower endpoint for TAVR.
So quite surprising, and I would guess that the results were driven by hospital utilization rather than some of the other endpoints like death or stroke. Is that right?
Yes, exactly. Death and stroke, if we look at the secondary endpoint individual and not combine, the death rate and the stroke rate are comparable, and the difference is driven by hospital stay, as you say, with a difference of P of 0.02 for the hospital for the rehospitalisation at 1 year in this population. Yes. But we know from the other endpoints that there were more AFib, atrial fibrillation, for example, after surgery. And we know that atrial fibrillation can lead to rehospitalisation. The difference was very important for the rate of atrial fibrillation between TAVR and surgery. It was 3.3 versus 28.8 at 1 year, for example.
Really remarkable findings in that you demonstrated non-inferiority and also superiority. And while some might say that this was achieved through the endpoint of rehospitalisation, I would say that itself isn't a very important endpoint for patients. Nobody wants to be in the hospital. Tell us about some of your other secondary endpoints.
Yes, so other secondary endpoint besides so much lower rate of atrial fibrillation after the aortic valve replacement with TAVR, we had a little more risk of pacemaker implantation with TAVR, which is also quite known. We had something which is very important, and we know, and this is the huge advantage of TAVR. We had 90% of patients who went home directly from the hospital versus half of the patient after surgery. And the median hospital stay was much lower. It was 4 for TAVI and 9 for surgery. So for patient, it's something they request. It's not only a procedure which is less invasive, like local anesthesia, but short hospital stay. They go home, they don't need readaptation. So these secondary endpoints are huge, and we could see that at 1 month, quality of life was improved at 1 month. It was comparable at 1 year. And also we have data about hemodynamics. Probably you are interested to know about hemodynamics at 1 year. So there was a core lab. So it's very interesting that it was a core lab led by Philippe Pibarot, who is very well known for all the trials. So the echocardiography were systematically performed before, at the procedure, at discharge, at 1 month, at 1 year. So this is very good. And in both arms, Hemodynamics were really excellent. It was, as an example, it was at 1 year we had 12 for TAVR and 14 for surgery. And for the RHEIA, it was 1.7, 1.8. So the two groups were brought excellent hemodynamics. There was no difference in mismatch. Severe mismatch was, of course, present sometimes because the annuli were small, but the difference was not significant between TAVR and surgery. And when we look at paravalvular regurgitation, which is also something which is known after TAVR, there was no severe, neither very few moderate, and the rate of mild was a little higher after TAVR than after surgery, but lower than in partner 3 again with the new devices, Ultra, etc.
How about the need for a permanent pacemaker?
Yes, the need for a pacemaker was higher with TAVR than with surgery. It was 8.8 at 1 year versus 2.9 after surgery. So this is, I agree that it was comparable in partner 3. Here it's probably lower with surgery, and the difference was significant, yes. But it's less than 10, so 8.8 is acceptable.
Remarkable findings. Did you also find any benefit in health status or health-related quality of life?
Yes, there was a significant differences in favor of TAVR at 1 month. And of course, this is related to the fact that it's a less invasive procedure than surgery. But as in other trials, it was comparable with surgery at 1 year because the patient had time to recover. So at 1 year, it was comparable.
So really an amazing trial, an all-women trial in which you demonstrated that TAVR using SAPIEN 3 or SAPIEN 3 Ultra was non-inferior and in fact superior to SAVR for the primary composite endpoint of death, stroke, or rehospitalization, and that these findings were driven largely by a reduction in rehospitalization, but also improvements in other important secondary endpoints, although they came at a cost of increased utilization of permanent pacemakers. Can you tell us about peri-procedural complications in both groups before we sign off?
Yes, there were very few, because procedural death was 0.5%. And for the TAVR group, we had the one coronary occlusion. There was no annular rupture, which is very interesting because we are in small annuli, we are with balloon expandable, and there was no case. There was one aortic dissection. The common complication, which is currently related to small annuli, in fact, did not occur. So this is also something very interesting. And same for coronary occlusion, which is really quite low. It's never 0, and 0.5, it's really acceptable.
Sure. So in women with calcific aortic stenosis that's symptomatic and severe, I would send them for TAVR based on your results. What are your thoughts on that?
I agree that I think the impact of this trial will be very important because the population is quite young. It's 73. They are at all comers, so the risk is low. The clinical endpoint are excellent at 1 year, even if it's driven by hospitalization. But hospitalization, it's something. It's not nothing. I mean, it's not a hard endpoint, but it's nobody, as you said, want to go to return to hospital after the procedure. And again, it's a much less invasive procedure. So these results are in favor of TAVR because with a less invasive procedure, which brings the patient home, which brings them to stay not long at hospital, they have this excellent clinical outcome, very good hemodynamics with few differences, of course, but still excellent result. Even some of them are different between surgery and TAVR. We have to say that we have data at 1 year. So of course, it's we are 20 years. We cannot talk about the future, but these results are very promising.
Fantastic. Well, thank you so much for sharing your results with us. Congratulations on your presentation, and we will look for the publication as well. Thank you so much.
Thank you.